Good evening, everyone. Welcome to this evening's webinar. Just before we start, I've got our usual announcements. If you have any technical problems, please try to rejoin, leave the webinar first and then rejoin. If your problem hasn't solved itself, then please try to contact us by typing in your problem in the questions field, and then I will try and help you out. We will have our introduction by the Eurogen program manager, and then the presentations will follow. We will have time for discussion at the end of this webinar, but you can type in your questions whenever you like, and then we will save them up for at the very end. I would like to hand over to Michelle Betty, the Eurogen program manager, to introduce today's webinar.
Hello, good evening everyone. I'm Michelle Batty and I'm the Programme Manager of Eurogen. Eurogen is one of the 24 European reference networks that were created and funded by the European Commission since 2017. And they all collaborate to help patients with rare diseases and complex conditions. And in our case, it's patients with rare urorectogenital diseases and complex conditions. And we're currently a network of 56 healthcare providers, all with experts in the areas we cover in 20 member states. So what do we do? Well, we aim to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for these patients with rare urorectogenital diseases and complex conditions. And they all require highly specialised surgery, so where the expertise is rare. So some of the activities of our network, well, we conduct virtual consultations. We have a secure tool called the Clinical Patient Management System, which we can use to hold cross-border virtual consultations. So if any clinician working in the EU has a tricky case, please feel free to get in touch with us via our website and we'd be delighted to help. And this service is free. We also collaborate on training and education activities. We have and clinical guidelines also, and we also have a patient registry, which is very exciting. So we can track the long-term outcomes of these patients over time. And then finally, we have also published a book by Elsevier, and it's on rare and complex urology. So without further ado, we're looking forward to a fantastic webinar this evening from our French team, and it's going to be on paediatric renal transplantation in patients with posterior urethral valves. And it's an absolute honour to have with us this evening. We've got Professor Alaa El-Ghanomi, who is Professor in Paediatric Urologist. He's head of the Department of Paediatric Surgery and Urology in Paris, and he's also the national expert in rare urinary tract malformations. He's ESPU President-elect as well. We also have Professor Julien Hogan, and he's Professor in Paediatrics, Head of the Department of Paediatric Nephrology, and National Coordinator of the Reference Centre for Hereditary Kidney Diseases in Children and Adults. And then finally, Dr. Mathieu Pesselon, who's Associate Professor in Paediatric Urology, and he's Chairman of the ESPU Educational Committee. And they all work at the University Hospital Robert Debreu, Paris, France. So the session is going to be divided into three key aspects about paediatric renal transplantation with patients with posterior urethral valves. And of course, they present very unique challenges. So the first aspect will be the nephrologist's perspective and advances in immunology. The second part will be pre-transplant bladder preparation and then intraoperative surgical challenges. And we collaborate with many stakeholders, and the supporting partners for this webinar are ESPU, Marvieux and Neurosphinx. and it is eligible for EACCME accreditation for live attendees, but you must remember to fill in the post-webinar survey within 2 weeks, please, to get those credits. So thank you very, very much to our French team, and we're looking forward to a fantastic webinar. I give you the floor. Thank you.
Good evening, everyone. Thank you for the kind introduction. I'm just going to share our slides. There you go. All right. So thank you for the introduction. So I'm Julian Hogan, and I'm a pediatric nephrologist here in Robert Debré. And so I've been asked to kind of put the topic of tonight in the context of the broader context of pediatric kidney transplantation. As you know, kidney transplantation is the treatment of choice for children with end-stage kidney disease. And this is really well shown on this graph, where what you can see here in the purple line is the life expectancy of patients on dialysis. And you can see, especially in the younger age group, that really there is a major decrease in life expectancy compared to the normal population, which is here in light blue on the top. And you can see in the middle, the red bar are the patients that have got a transplant. So you can see that although it doesn't go back to the life expectancy of the general population, there is a major improvement, especially in children when compared to patients on dialysis. So first, it's really important to transplant those patients, and it's important to try to transplant them early. And of course, you know, the benefit that we get from this transplantation will depend on the long-term graft survival. So what we want, especially in children, is to have graft that will last long. And so how do we do that? What we know is, first of all, it's very important to try to do preemptive transplantation. Why? Because this is really has been associated with better allograft survival. And here on the left, you can see this is a recent meta-analysis of various cohort study, mostly in children. And you can see that basically almost all of them really show a benefit of having a preemptive transplantation. And those results are always debated sometime, and especially some people will argue that it may be because you have more living donors in these patients. But actually, that's why I put this graph from an older paper that was published in the New England. That was only, so it was adult recipients, but it was only patient receiving living donor transplantation. And you can see that even in this population, preemptive transplantation was associated with a longer allograft survival. So we want to transplant those patients early, and we want to try to transplant them preemptively. I think you own that the issue is always to get those allograft. And I think because it's a European audience, I think it was interesting to look also at the disparities that we have in Europe. And on the left, what you can see is the difference in the rates of living donation in European countries. So you can see that it goes from about 10 to 20% in countries like France or Spain to almost the majority, or if not all, of the transplant in other countries. And what is interesting to see is that if you basically compare that to the rates of preemptive transplantation, it's not totally the same, of course, but what you can see is that most of the preemptive transplantation in most of the country are from living donation. So basically, the idea is if you want to do more preemptive transplantation, you will have to perform probably more living donors, with some exception, like Spain, for example, that is able to do a lot of preemptive transplant from deceased donors. And as you know, that also means that you will have to use adult donors by definition for those transplantation. I'm not going to go too in more detail in the discussion of how do we get deceased donor transplantation, but you know also that there are major disparities between countries in Europe. But the general idea, if we want also to have more access, quicker access to deceased donation, it requires a strong pediatric priority, try to reduce opposition rate, and nowadays also use more marginal donors. And that's something that is coming more and more, whether we will use smaller donors or DCD donors. And because we are transplanting those patients early, that means that we have a lot of patients that are small recipients, and we'll talk about that more after that. But that is really a challenge for us because we end up transplanting a lot of small recipients with adult donors. And as you know, there are some challenges with that. So on the left here, you see is the risk of allograft survival for small recipients younger than 2 years old, depending of the ratio between the donor and the recipient height. And what you can see is, as we all know, we don't want to have very small donors for those small recipients, but we don't also, there's also an increased risk of allograft loss with when the donor height is very high, like you see here. And if it's not only graft loss, even in patients where actually the transplant is successful, there is this very interesting study from the Netherlands that looked at the prevalence of fibrosis on the biopsies of those children, depending on the body size area. And what they showed is that smaller recipients will develop more fibrosis on the biopsy. And the idea behind that is that when you transplant in a small child with a large kidney, then there may be hypoperfusion either during the transplant procedure or even afterwards, and that will result in fibrosis, and at the end of the day, that will result in decreased renal function. So these are really important questions to consider when you are basically choosing and preparing your patients. If we are talking about allograft survival, the good news, as you know, is that kidney transplant is working really well and that the outcomes are actually improving with time. And here, these are French data, but we see similar data in many other countries where you see that there is an improvement with time in kidney allograft survival. And for example, you can see here that the more recent cohort, we have a 10-year kidney allograft survival about 70%, which is really excellent. Of course, we all hope to do better, but that's really, really good. When we look at why patients are losing their graft, we see that more than half of the cases is from rejection. And so for us as nephrologists, a main concern for us is to prevent and treat those acute and chronic rejection in those patients. However, I want to point out that it's different. When you look at the reason why the patients are hospitalized, so basically the complication that they will have after kidney transplantation, rejection is not the most prevalent problem that they have. You can see that's here in red. You see that the main reason why our patients are hospitalized is because of infection. And if we look, we did this study on claims data in France, and if we look at the type of infection, we always worry about opportunistic infection, but actually the main driver of all those hospitalizations are UTIs. And I think as urologists, you are very well aware of that. But again, this is something that is very important because even if in patients that don't have posterior urethral valves, it is an issue. And it's going to be even a greater issue in those children that we have to consider when we prepare them for transplantation. So that's my final slide, because to kind of round up all that, why is that really important? Why all those questions are important for patients with posterior urethral valves? Well, I just put here the data from our centers, and you can see that among about 500 transplants, there was around 50 patients transplanted with this pathology, so about 10%. I think what's really interesting to see is that a lot of them are actually small recipients. You can see that the median weight was 25 kilograms, and that about 40% were less than 20 kilograms, which in most centers we consider as small recipients. And so we know that those recipients face specific challenges. We've talked about the risk of vascular thrombosis. We've talked about the risk of hypoperfusion. And we talk about the challenges in choosing the right donor, whether it is a living donor transplantation or a deceased donor transplantation. And we also know that those patients are at very high risk of urological complication and UTI. Of course, my colleagues will talk about all the bladder preparation and evaluation before transplantation. But for us, even as nephrologists, we have to anticipate the risk of also infection post-transplantation and see how we can manage those patients afterwards. And so that really kind of explain why we need a pre-transplant multidisciplinary evaluation to try to minimize all these risks and to choose the optimal donor for those patients. Thank you. And I'll let Matthew continue.
Thank you, Julian. So the second part will be what we need to know before a renal transplantation for patients with PUV. So we face surgical challenges when we prepare a patient with a PUV and a renal transplantation. There's 3 factors we can include: low body weight, the need for preemptive transplantation, and the crucial importance of optimal bladder preparation. And we need to keep in mind that a second transplantation will follow in the future. And then we need to keep in mind also that children are not just small adults. They have key factors like recipient size consideration, much more viral infection, problems related to growth, and psychosocial issues. We need also to remember that preemptive transplantation is optimal in this specific group of patients. And in this French registry, at 10 years, the probability of graft survival was 86% in preemptive kidney transplantation, in comparison to 67 in non-preemptive kidney transplantation. And the difference was massively significant. What we know also from our experience and from the literature is that renal transplantation in low-weight children less than 20 kilograms is feasible and even safe. And in the last meta-analysis, there are good long-term patient and graft survival rates of over 90% and 80%. But when you are a pediatric urologist, you need to focus on bladder function in these specific patients. They have a voiding dysfunction with a wide variability. It comes from hyperactive bladder to hypocompliance and sometimes areflexive bladder. In some selected cases, they present valve bladder syndromes with hyperactivity, low compliance, and high-grade reflux. So first, you need to do, before any renal transplantation, a bladder evaluation through a clinical evaluation with voiding diary, with non-invasive uroflowmetry and the measurements of post-voiding residual. And in selected cases, you will need video aerodynamics in case of reflux to do a discrepancy between low and high pressure and to evaluate the bladder compliance. So you can categorize this patient with 2 types of high-risk bladders. One in case of overactivity, reflux, high pressure, and low compliance, and sometimes because of enlarged bladder and acontractility, which can lead to post-voiding residuals and UTIs. So first, evaluate the bladder and then prepare the bladder. And you need intensive session with the child and their parents by your dedicated educational team, including a pediatric urologist, a specialized nurse, and a psychologist. So, if you want to summarize what could happen in this case of high-risk bladder, you can do a preoperative close follow-up and then a postoperative close follow-up with a video aerodynamics 3 months after transplantation. And in case of favorable or unfavorable condition, you could choose to do no surgery, or you can sometimes offer, in selected cases and a few cases, a bladder augmentation. For example, in a case of a non-functioning bladder due to bilateral nephrectomy and neonatal anuria, you need to think about the bladder And you can offer bladder stretching, which can improve the bladder capacity and offer a better graft survival. So let's walk into more illustration cases. This first case is a patient with a PUV and an early infant end-stage renal disease. At the beginning of the evaluation, the bladder capacity was 17 millimeter, but after bladder stretching protocol, using a 24-hour bladder infusion during 3 weeks, the bladder capacity increased massively to 180 milliliter. In this second case, with a child who had several surgery, we discovered missed PUV, and we decided to do a PUV section and under general anesthesia to do urodynamics. At this time, we decided, because of unfavorable condition, to do a left nephrectomy because of non-functioning left kidney, and to use the ureter as a mitral funnel channel. After the renal transplantation, and 3 years after this transplantation, the patient could stop CIC. The last clinical cases is a 5-year-old patient with PUV who had an evaluation of his bladder pressure under general anesthesia, and we discovered a valve bladder syndrome with low compliance, high pressure, and overactivity. And in this case, we decided to do a unilateral nephrectomy to use the ureter and the pelvis as a bladder augmentation to increase the bladder capacity and to create a mitral funnel channel with the appendix through the umbilicus. And then this patient is now ready for transplantation 5 years after this major surgery. So if you want to summarize what could happen when you do bladder evaluation and preparation, sometimes, and more usually, you offer no surgery before any transplantation, but sometimes you need to decide between incontinent diversion, sometimes bladder augmentation with the ureter, and in a few cases, a classic bladder augmentation with ileum. So in our experience, close to 50 patients with PUV we need a transplantation use CIC through a mitral funnel channel, and many of them had a major surgery before renal transplantation. If you divide this group of patients with PUV requiring a renal transplantation, you have 3 groups. The first one, the patient has only symptoms. The second one, group 2, the patient has lower urinary tract symptoms requiring medication like anticholinergic or alpha blockers. And the third group presented bladder dysfunction with valve bladder syndrome requiring CIC and medication. What will happen after surgery? In the first group, with no symptoms, no child worsened their bladder function after renal transplantation. In the second group, the group with a patient with symptoms requiring medication, 80% of them did not require any medication at the end of the follow-up. In the third group, with a bladder dysfunction, sometimes you can stop CIC and stop medication. But 70% of them could be instructed to stop CIC, but 30 patients still have valve bladder syndrome requiring CIC, oxybutynin, and alpha blockers. So what does it mean? It means that renal transplantation can improve bladder dysfunction thanks to the decreasing of polyuria and the disappearance of polyuria. So you need to think always that bladder augmentation is not always required before renal transplantation.
Thank you, Mathieu. So now we are going just to talk about some surgical difficulties and the challenges while you're already did the prepare the kidney, prepare the general condition by the nephrologist, and then you have to do the transplantation. And in just show in our experience in the last 12 years, with 21 pseudocell valve. And as Professor Hogan said it, that nearly 10% of our patients are pseudocell valve. And you can see that, of course, the rate of low weight is higher than the other population. And we had 3 graft lost, which means 14% of the patient has lost their graft, but all of them due to vascular thrombosis and not due to bladder problem, as it was very early loss of graft. 2 of the 3 of them were young children with a small weight below 16 kilograms. 14% of them, they had febrile UTI in postoperative, and 3 of them, they had febrile reflux. When we see this situation in other centers, and especially in the first paper by Lochiel, and that we can see that the survival of the graft is nearly the same, even better in procedural valve than in controls. But you can see that even so, you have 10 urological complications has been reported, and 5 of them were reoperated children. In the Madrid series by Lopez Pereira also showed that there is a significant increase in UTI, especially after in patient with procedural valve and associated with bladder augmentation. And this is coming in all the review of the literature, that as far as you are doing more surgery to prepare the bladder, or to do reimplantation, to do nephrectomies, or to do other surgeries in the bladder, your child will have more febrile urinary tract infection and complications after the transplantation. So when we come to the question, should we augment or not augment? Should we do it before or after augmentation? In the old publications, we have, considering the valve bladder, indications were much more easier and much more important in the series. It was mainly to avoid post-kidney transplantation UTI and loss of transplant. It's secondary to the problem of the bladder condition. But the main thing that we have to reconsider the indication for bladder augmentation and to see, because in the other group where the augmentation were done after transplantation, the complication, we don't, in this case, you would avoid the complication of peritoneal dialysis, and you also avoid the bladder augmentation in oliguric patients, as the bladder augmentation can have more complications. And then during the transplantation, if you do it while you have a bladder augment, this also can increase the complication, and of course the metabolic complication can be an adding factor for it. So many reviews and also a good series has been published recently, where in this one, where in Seattle group, that again the median age was 11 years and 1/3 of the patient was preemptive. And you can see here the rate of bladder augmentation is quite important, 16% of them. The graft function outcomes were similar when compared to matched cohort without lower urinary tract dysfunction. But again, if you have a patient with CIC, you have higher rates of UTI, but without impact on graft function. But it would increase, of course, the rate of readmission in the hospital. In the largest series published till now, which is the series of Australian and New Zealand dialysis and transplant registry, they have for 126 posterior valve transplanted, the graft survival rate in the first 10 years after transplant were similar, but there was increased risk of graft failure beyond 10 years for recipients with posterior valve, which of course this supported the hypothesis that bladder dysfunction in posterior valve may have a determinant effect on a long-term graft function. So what to choose, left kidney or right kidney for your transplant? I think there is no difference posterior valve or not, but they are joining the group mostly of multi-operated children and small size, small weight. So the left donor kidney normally in general is preferred over right due to anatomical factors, but there are some publications show that there is no difference, and especially in retrieving the donor kidney with robotic is there are more centers now are doing it right or left when using the robotics. But for pediatric recipients, in our preference, we would do first transplantation on the right side, and if you use inferior vena cava or aorta, it's less complicated. And for like this, we leave the second transplantation on the left side. And then when you have a challenging operation, challenging recipient, especially with vascular complications, vascular anomalies, and also high ratio donor recipients, will find it interesting to push the investigations for the 3D CT reconstruction. But even so, here in these specific cases where you have here a total thrombosis of the inferior vena cava, except this very small part, which is subhepatic inferior vena cava here, and the child is having his anuric, and they had already bilateral nephrectomies. So in this case, we would use one of the recent applications of planification of surgery, like this one with a visible patient. And here we can see that the collaterals are behind the psoas muscle, so they cannot be really used to anastomose do the vascular anastomosis. So now we will see that we can see that the inferior vena cava subhepatic is still present, but can we put the donor kidney with the size of the donor, is it fit in this place or not? So even in this, you can take the scanner of the donor, you can do the sizes, and then you put the kidney virtually in it, and then of course transplantation is much more complicated than virtual, but here it gives us the idea that you have to put it in orthotopic position, not in the lower part as usual, and also it is visible to do it with the main artery, the aorta, and the inferior vena cava. So this is, of course, is very helpful for this. So in general, we would do it retroperitoneal. Many centers, they would do it transperitoneal, but in all our patients, we did it in extraperitoneal approach with the G incision. We do it always end to side, especially the small babies. Inferior vena cava and aorta, we use resorbable suturing. We implanted the ureter in the bladder with a dish Gregoire, and we always try to avoid the transurethral anastomosis in patients with posterior valve, as the ureter most of the time are pathologic, and we leave a GG stent for 3 weeks. We do immediate postoperative renal ultrasound in the operating room after skin closure to have an early postoperative ultrasound, and after that to compare it to after transfer in the intensive care unit. And then we do serial imaging depending on the result. And every time there is discordance or some concerns about the vascularization, we do a multidisciplinary meeting with radiologists, nephrologists, surgeons, and intensive care pediatrician to see if we need to go further or not. If we need to go further, we would go through an angio MRI or CT scan. It depends on your availability. And then we do it in case of your ultrasound abnormality, suspicious of urological or vascular complication. And of course, if there is clinical radiological discrepancy between the urine output and the creatinine and biology, and also the result of the ultrasound. And then you will see there we have some case, you can, in this case, you can really see the extension of infarction with this imaging. You can also diagnose, like in this clinical case, which you have a 10 years recipient boy, perfused kidney without renal output. Well perfused, but there is no renal output. Initial ultrasound was normal, and then follow up, there was progressive alteration of criteria, high resistant index velocity, and there is no medical explanation. He is well hydrated and has no hemodynamic disturbance. So when we did the ultrasound at 27 hours, we suspected stenosis at the arterial anastomosis here. So in this case, we did a CT scan immediately, and in this case, it's emergency. And we can see here the stenosis with a high risk that will do thrombosis. So in such case, we go back again, even 27 hours after, you can go back, you try to revascularize the kidney, and this will take the internal iliac for this to do end-to-end anastomosis, and we recover the kidney after that. Another challenging thing, which is the discrepancy, very important. And if you have allograft compartment syndrome diagnosed, in this case, you have a salvage. Either you can close it with just a mesh or like a Vicryl mesh, or if in our case here, we could not, even the mesh could not work, only skin could not work every time we had the compartment syndrome. So in this case, we would cover it with a temporary Gore-Tex for 4 to 5 days. And then when the child is good, the kidney is functioning well, we go back to the operating room, and then we remove the non-resorbable plate, which is the Gore-Tex, to put another one like Vicryl, and then we close the abdomen after that. And this, in this case, you would save the graft. So if we can do some conclusions and some keywords, it's very important that all the hospital is involved in your program, especially for these complex cases for procedural valve. It's a transplantation is a perfect model for multidisciplinary management of children. And our conclusion, the three of us, that to take home messages, the keys points are renal transplantation in children is challenging, especially procedural valve. Strict and extended bladder evaluation before transplantation is mandatory. The children with high risk of end-stage kidney disease, we have to prepare them from their birth for this. Avoid bladder surgery when it's not needed. Avoid reimplantation, nephrectomies, which you can use them after for either ureterostoplasty, either Mitrophane of urethral. Early and active management of the bladder. All efforts to be done to keep the native bladder functioning. So we need to avoid anuria, we need to avoid bilateral ureterostomy. If needed, we start CIC early, even through a Mitrophane of channel before the renal transplantation. We really believe that bladder augmentation must remain an exception before transplantation, and that post-transplantation pediatric urology follow-up with bladder evaluation is a must. Thank you so much, and thank you for my colleagues for their presentation. And now we're open for discussion.
Yes, great. Thank you very much. We are indeed open for discussion. So you have a Q&A section in the bar below with a question mark. That's where you can type in your questions. So we will wait a couple of minutes for people to type in their questions if they have any. In the
Still have
chat.
no
in-
questions?
Not
One
yet.
thing,
So
hello.
I will
Hello.
use this moment to mention that the webinar has been recorded and that I will send the link to the recording to everybody that registered for the webinar tomorrow via email. I will also put the recording on our YouTube channel, so make sure to check out our YouTube channel and subscribe for past webinars. You can also find them on the site. I can see that somebody has passed through a question. Could you maybe read it out loud so everybody knows what's being asked and then answer it?
I can read it. So thank you for the presentation. So the question is, what are the long-term functional outcomes of renal transplantation in patients with posterior urethral valves compared to other causes of end-stage renal disease in pediatric patients? So that's the first question. And the second one is, what is the optimal pre- and post-transplant management of the urinary tract in PUV patients to minimize the risk of graft dysfunction and infection? That's a broad question.
You want to answer the first one?
We have answered, but you can.
Yeah.
But
Compared
Yeah.
to
So the long-term outcomes.
the functional
So-
outcome
well,
of renal.
so I think the long-term outcomes of PUV are really good overall when you compare them to other causes of kidney failure. So you also always have to be a bit cautious when you do that, because if you compare them to all the other patients, you may want to compare them only, for example, with other patients with uropathy but not PUV. That might be a better comparison. But overall, the long-term graft function is very good. But we know that, as it was mentioned, that some patient will improve, but some will still need to have catheterization, for example. And we also know that they have a higher rate of infection that can impact long-term graft function, of course.
And for the second question, I think the optimal, of course, the pre-transplant, that's what Matthew has explained, that you have to have really invasive and aggressive evaluation of this patient, even if they need to do a CIC before, need to do metroponophy, so before we would do it. And in post, I think the most important is that even if everything is going fine, we need to do early evaluation of their bladder. So in our center, we do it 3 months after the transplantation, when there is no more double G stent and the child is stable. In this case, we would do this. And of course, don't forget, if they are having a CIC, that they should restart very early. That's a clear sheet.
So how to start evaluation for pre-transplantation bladder assessments. So as we said, you will use clinical evaluation through a Voiding diary. Then you will ask the child to do uroflowmetry, and you need to measure post-voiding residual. And if the patient needs a transplantation, you absolutely need to do a urodynamics, and we use a concomitant cystography, VCOG, called BD urodynamics, because we want to be sure that how to evaluate bladder pressure and to evaluate if there's any reflux with high pressure or low pressure. So before any transplantation, you will need BDO urodynamics to evaluate the bladder and to offer the optimal preparation to the child and his family.
So a question for surgery again. Could you mention any exception situation in which you could do a bladder augmentation before the renal transplantation? Yes, there are some exception situation. We, in our cohort, which is 48 posterior valve transplanted, we have exactly one bladder augmentation, classic bladder augmentation, which means ileocystoplasty. And that was a multi-operated child with associated Hirschsprung disease, multi-operated and neurogenic bladder also. And his bladder was impossible to bring it back. And it was a cerebral valve bladder, but it was neglected, and we had him very late. And this child, we tried the CIC first, and the bladder did not improve at all. It was impossible to do for him also the ureterocystoplasty. So we did for him bladder augmentation before the transplantation. But he was having a diuresis. He was having a urine output, which is a second child. He had total anuria, and the bladder, even after stretching, it did not work. And we had to do for him precare, which is ileal conduit. And then after the ileal conduit, it will be, of course, integrated in a bladder augmentation. The others are the one which Matthew showed as ureterocystoplasty. We do it in borderline case, and we have, I think, one case also, or one case only till now, that he is preparing for future transplantation. So it remains very exceptional. But of course, in cerebral valve, I mean, if you have a very small bladder and you cannot by all the means improve it, in this case, of course, you will need to do bladder augmentation. Another question?
So which will be better after transplantation, ileal conduit or ureterostomy? In a case of solitary functional kidney, which is actually the renal transplant, in a patient with unthreaded bladder, I will always say that you need first to evaluate, and you should try to use CIC and medication, anticholinergics and alpha blockers to try to increase the bladder capacity and the compliance before offering any major bladder surgery, which is not helpful at the end.
And then the question is that what you prefer, ileal conduit or ureterostomy? Honestly, we receive as a center, we have also overseas patients that they come with. We had one with conduit, other one with ureterostomy. Both are feasible. We prefer not to do neither one, because the problem is, what would you do after? I mean, it's of course ileal conduit, you can integrate it in a bladder reservoir, in ileal reservoir or bladder augmentation. Ureterostomy, you need to dissect the ureter again, and maybe you will have problem with short ureter after. But of course, they are, if you don't have a choice, you of course you have to do. But I would prepare reservoir or bladder augmentation before the transplantation for these specific cases.
So maybe, how can we avoid transplant the patient with peripheral valve? What could be measures plastic surgeon may take before going to transplant? Well, I think that, well, the first thing is early diagnosis. And so, as we said, the patients that will be transplanted are either some very severe cases seen from the start. There are some of those, but maybe half of our cases are also patients with late diagnosis or late referral. And so I think these are the patients you can basically do something for. So again, early diagnosis. So ultrasound screening during the pregnancy is really a way to diagnose it and to take those patients early. I think my colleagues will tell that really it's like early resection of those patients, and then a close follow-up
As pediatric nephrologist.
With the pediatric nephrologist, of course.
I think this is really a measure. If we would say that the progress in pituitary valve in the last 30 years is the modern care and intensive care by the pediatric nephrologist from day one after birth, which means that they having a good, for us, it is, we cannot see a pituitary valve patient without a pediatric nephrologist. I think this is more as important as the surgeon. Yes, there's water. He's asking, thank you. Water, no, we don't have any patient who is in vesicostomy with kidney transplantation. We always dealt with the kidney, with the bladder before the transplantation. If it's having vesicostomy, we would close it, and even we can divert with refluxing ureter if we have a doubt about with a bladder, borderline bladder. And Alexander Springer is asking, this is a very interesting question, is considering that the posterior valve bladder, of course, is not a neuropathic bladder. So what is the role of urodynamics? He thinks that the urodynamics is limited for this. I think for us, it's especially if you have a hypertonic, hyperreflexic, hypertonic bladder in posterior valve, because it's not neuropathic, but they are there. I mean, anybody would follow and you know it, Alexander also, when you follow a bladder and the bladder is still with limited capacity, high pressure, you have to know if the reflux which is inside, is it a reflux low pressure or it's a reflux high pressure. This is the need to do video aerodynamic in such a case to be sure that about the character of the bladder of the reflux. And then after that, how can we judge if this bladder is having a high pressure or not before doing the transplantation? If we don't do urodynamics, I think it will be very difficult to re-implant the ureter in a bladder that you don't know if it is on high pressure or not. I hope that we answered your question.
So Mahmoud Marai asked us two questions. Could you please tell us about transplantation in case of bladder diversion, vesicostomy, ureterostomy, and if the bladder is in poor condition, would you transplant into a ureterostomy temporarily? So in our experience, we try to avoid any diversion just before the transplantation. So all the bladder are usually closed, and we try to avoid to have any stomy to decrease the risk of graft dysfunction after the renal transplantation. So we try not to have a diversion, and it's not in our experience that we have this such case. So what we said actually, in case of oliguria and diversion, we try to close the bladder and to stretch it. We use 24 bladder infusion for 3 weeks to increase the bladder capacity and to show the patient, the nephrologist, and our team that the bladder capacity can improve, and that then when we decide to do transplantation, preemptive transplantation with a living donor, we stretch the bladder for 3 weeks, and then we do the transplantation on day 1, and then we take care closely after surgery that the bladder function is appropriate.
I think also we have to consider the area and the environment of the patient when they arrive in the center. So that is the question of Sadaf. I think yes, Sadaf Karachi, the Syut Center, and this of course you have so many patients who should arrive from far with vesicostomy for this, and we have them in some overseas patients also when they come, or in our institution also, that they had this as temporary vesicostomy, would always close it, as Matthew said, but the stretching and functionalizing the bladder is also need a lot of education, and the nurses they educate the family to do it. It's a 24-hour perfusion in the bladder through a suprapubic caster, a very small suprapubic caster, 5 French.
So it's the question of Antonin. So we use a 5 French suprapubic tube, and because the urethra is too fragile and sensitive, so that's why we can't use a Foley catheter. And then they came to the clinics for instruction by the dedicated nurse team. And then for 3 weeks, they will use a pump at home. And the flow is 2 milliliter per kilograms per hour. So we start usually at 0.5, and you can increase to 3 milliliters per kilograms per hour, but usually could be painful to the bladder. So there is a kind of protocol, 0.5 for 1 week, 1 milliliter for 1 week, and then 2 milliliters for 1 week.
I think we have a question here. I think we can so the timing of bladder augmentation post-transplant, if you really need to do one?
I think when you need, you have to do it.
Yeah.
When it's needed, you have to do it. Of course, you cannot do it while very early post-transplantation period. I mean, the 3 weeks or 4 weeks, you need to wait until the child is stable. So you have to do a continual drainage of the urine by any means until the child is good.
Right, and we have another question on whether it is okay to wait a few years prior to transplant so that the recipient grows and the allograft fits into the abdomen. So I think as you've seen, we always want to go as fast as possible to transplantation, and the reason for that is there are many studies showing that time on dialysis is actually associated with increased risk of cardiovascular morbidity and mortality long term. So we know that the longer the children stay on dialysis, basically you are impacting their life expectancy. It really depends on, I think, where you work. So I would say in our institution, for example, if the child is really small and then the parents are very tall, and so there is a major mismatch in size, then in those cases we'll prefer a deceased donation with a smaller donor. So we'll have to adapt the donor. Again, that depends on where you work, whether there is a deceased donor program or not. So I think you have to take into account where you work. But again, the idea is, unless it's totally not feasible, we should try to go as fast as possible to transplantation. Although we have to acknowledge that in some cases, again, bladder preparation is important. So we have delayed, not because of the size mismatch, but because we wanted the bladder to be ready for transplantation. We have delayed, but again, it's delaying from a few months. It's not delaying for years.
So there is one question by Thibaut Blanchon from Toulouse about, do you need video dynamics after bladder stretching? So usually you need you do bladder stretching to increase the bladder capacity, and you don't always use video dynamics after bladder stretching. You can use only, for example, VCUG, but it's a good question, and it depends what you need to answer when you use bladder stretching before transplantation. And there was a question about, when do you recommend nephrectomy in case of high-grade reflux? A good question, because it depends if the reflux is symptomatic and leads to a recurrent and febrile UTI. So in this case, you will think about nephrectomy. If you have high blood pressure, you will need to do a nephrectomy too. So in a general case, you can do it just before starting the transplantation. And in selected case, you will think about, is this working? Is the function of this left or right kidney is working? And if you need to use the ureter as a Mitrofanoff channel. So it depends really of a specific case of this patient.
And sometimes you need to leave the refluxing ureter as a pop-off of your bladder during the transplantation. And we try always to keep the kidney with urine output. Or always, even if it's a preemptive transplantation, because if any complication that it doesn't work, transplantation, it's much better that the child grow up with a urine output than dialysis without urine output.
So there is a question about the use of anticholinergics or Botox injection. So in our experience, the patient are really responsive to anticholinergic medication, and we don't usually use Botox injection. It could be used if there is no more effect by anticholinergic, but it's not so much frequent in patients with PUV. And about bladder neck dysfunction, it's true that in our experience, we use alpha blockers because they are first, the patient have not too much side effects with alpha blockers, and it's decreased massively and significantly the bladder neck pressure.
This is the last question. It's a difficult one from Shobal Lakour. He's asking, they have a case of pediatric patient, end-stage renal disease secondary to valve, and he's on hemodialysis, and they want to transplant him. But even with cycling the bladder, he's still having a contracted bladder volume of 50 ml, unable to improve. Of course, I mean, as we said before, if it is really you have done the cycling, it's very important to know that cycling, either it's a natural cycling that he was diverted and then we'll undivert the patient, or it is cycling, artificial cycling. If we do artificial cycling, it needs to be like urine output, not with a catheter that we just increase manually the capacity by pushing the syringe. So we need to do really a perfusion, 24-hour perfusion for it. But if at the end it doesn't work, of course, the approach that you have to augment the bladder. There is no other solution for this.
But in this case, you could use perhaps the ureter and not only the
of course, you have to see. I don't know the case. So if you have the ureters, you can use the ureter. But in this case, you need also to evaluate the ureters after if the ureterocystoplasty is good or not.
Do we use anticholinergics
Yes.
with bladder stretching? Yes.
Yeah. So again, Murray is asking always a very difficult one. Have you needed to place a Mitrofanov to achieve overnight drainage instead of an augmentation in your series? I think yes, we did this. Much more Mitrofanov is used especially for the overnight drainage. And sometimes it's for even hypocontractile bladder with severe residual and infection. In this case, yes. And we did not talk about the diversion because we are a bit very keen about it, that we put for this uropathy, especially valve with possibility of transplantation, we always put the Mitrofanov in the umbilicus, which means midline. So like this, you can do the right iliac fossa transplantation without difficulties, and they will have always a second one the other side. And in this case, you only use the midline for the Mitrofanov.
Great. Thank you so much. There were a lot of questions. Yes, exactly. The last comments that are coming through are just thanking you, which leaves me to thank you very much for the interesting presentations and also the elaborate explanations on all the questions. We are a bit over time, but I think it was good to have that time for discussion. So like I mentioned before, the webinar has been recorded and I will send the links. Make sure to fill in the survey after the session has finished. Within 2 weeks' time, because that means that you will get a EACME certificate for it. I think that was everything I needed to mention. So again, thank you very much, gentlemen, for this
Thank you.
amazing webinar. I really enjoyed it, and I wish to see you again soon. Have a good evening.
Goodbye.
Thank you.
Bye-bye.
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 Thank you, everybody, for attending. Bye-bye.